when a young 20-year-old female gets diagnosed as ocular cicatricial pemphigoid and is started on systemic immunosuppression, that includes cyclophosphamide as one of the drugs because of a manifestation with dry eye and cicatricial changes, one needs to probably take the responsibility as an ophthalmologist as to whether you are right or not in initiating this kind of a therapy in a very young individual such as this. At the other end of the spectrum, you have a 60-year-old who is diagnosed as possibly rheumatoid arthritis and is treated and managed as that by the rheumatologist and the ophthalmologist for 6 years, with continued worsening of the ocular surface and the eye condition over a period of time. It again makes us stand and wonder as to whether we are right in diagnosing a patient who presents to us with a picture such as this. At the extreme end of spectrum, you have a child like this who's just 3 years old, and this is the picture with which she presented to me in 2023. You can see the status of the eye, and this is the same child 2 months back.
मैं डालती हूँ आपके यहाँ. Okay? कौन से आंख से दिखता है? मैं दिख रही हूँ? अभी? Same?
So what exactly was done for this child to visually rehabilitate her from the picture that you see on the left-hand side is something that I shall let you know as we go by in the talk today. And this is another patient, a 55-year-old male with Stevens-Johnson syndrome, who underwent mucous membrane grafting with fornix reconstruction, a cataract surgery, and uses scleral contact lenses. This is the picture from 2025. So since when have I been following him up? Well, this is the series of pictures. What you can see there is probably 2014. Is that when we started treating him? Well, no. This was how he presented to me way back in 2002. So the idea was to try and show through these few introductory slides about the perseverance, about the commitment, and about the rationality with which an ocular surface specialist needs to approach conditions, and what better condition to speak about on this morning but cicatricial conjunctival disorders, from clues to clarity. Let me at the outset thank Kekesh, the entire hospital, and especially Dr. Mohammad Ahad for having invited me here and having this opportunity to share and discuss with you certain aspects regarding cicatricial conjunctival disorders. I was already introduced. Thank you for that very kind introduction. But a word about who we are. Code Eye Care stands as a center of excellence for cornea, ocular surface, and dry eye that was co-founded. Rather than leaving this as a slide to come at the end, I thought I should acknowledge the fact that Dr. Bhaskar Srinivasan, whom I call my work sibling, and myself have founded this Institute of Excellence that stands as a beacon for compassion, optimism, dignity, and empathy, values that are extremely essential when you treat patients with ocular surface disorders. So what exactly are the pitfalls that are associated with the diagnosis? Cicatrization is a process which can irreversibly alter ocular surface integrity. And while cicatrization is central to the two most common diseases that we see under this umbrella, Stevens-Johnson syndrome and ocular cicatricial pemphigoid, the challenge lies in differentiating these conditions from other diseases that can also cause cicatrization, which is why, as I started off with those two slides that I shall come back to again, misdiagnosis and missed diagnosis are two things that happen very commonly under this vast spectrum of conditions that we call as cicatricial conjunctival disorders that leads to unnecessary intervention and delayed interventions, respectively. Cicatrization is a process of subconjunctival fibrosis, which is a chronic condition that leads to alterations of the conjunctival architecture, which could be potentially sight-threatening. All of us are aware of the manifestations of cicatrization, which could be in the form of a subconjunctival scar, symblepharon, ankyloblepharon, phoneal shortening, keratinization, and punctal stenosis. And when you look at the broad conditions that could lead to cicatricial conjunctival disorders, I think we can categorize them into immune, infective, trauma, masquerade, and others. And it is probably the immune conditions that we see most commonly, under which we have Stevens-Johnson syndrome, OCP or mucous membrane pemphigoid, graft versus host disease, atopy, sarcoid, and autoimmune bullous diseases. Trachoma, of course, is quite prevalent in both your part as well as our part of the world. It was, but currently it has been eradicated from both these areas. Ocular burns is another area that leads to cicatrization that I shall be speaking about in my lecture on chemical injuries in the grand rounds. The associations of cicatrization are not just limited to the conjunctiva, but they extend beyond to involve the entire ocular surface, including the limbus, the tear film, the cornea, and the eyelids. And you also have other ocular and systemic comorbidities that one needs to be aware of. So Stevens-Johnson syndrome and ocular cicatricial pemphigoid. These are the two most common conditions. Unfortunately, acute Stevens-Johnson syndrome, I'm sure here, I don't know how it works here, but in India, not too many ophthalmic institutes are associated with multi-speciality hospitals. So our access to patients in the acute stage is at times limited, and we step in only when the patient gets discharged and is subsequently referred to us for management. So when you look at the comparison of the definition between Stevens-Johnson versus OCP, this is a type 4 hypersensitivity reaction. It's a one-time episode that tends to leave behind chronic ocular sequelae, whereas mucous membrane pemphigoid or OCP is a type 2 hypersensitivity reaction that has an ongoing process in the eye. The onset, the history is very characteristic, and usually that is enough for us to differentiate between these two conditions, though at times you could have a confusion or a dilemma with respect to diagnosis in these conditions. SJS versus OCP, what are the most common presenting features? You have very similar cicatricial changes in both these eyes, but SJS, the specific features which are characteristic to Stevens-Johnson syndrome, is the lid margin keratinization, which you very rarely see in patients with ocular cicatricial pemphigoid. Unlike what we commonly think of, the puncta are usually open in patients with Stevens-Johnson syndrome, whereas in ocular cicatricial pemphigoid, the more specific changes include a medial canthal keratinization. Punctal stenosis is more seen in patients of OCP rather than in patients of Stevens-Johnson syndrome. And one feature that is very characteristic is usually dry eye that sets in very early in patients of SJS because of the scarring that occurs in the superotemporal quadrant, versus dry eye that occurs quite late in the process of ocular cicatricial pemphigoid. They usually tend to have oral lesions, which can point towards the diagnosis of mucous membrane pemphigoid. And in most instances, when you ask for a history of oral lesions, most of them will answer in the negative. And I will again show you why that is important as a pointer that tells us whether we are dealing with mucous membrane pemphigoid or not. The diagnosis of the two conditions, as far as SJS is concerned, it is quite evident with respect to the history that these patients present with, whereas in ocular cicatricial pemphigoid, it is the tissue biopsy, which is the only investigation that can actually tell us whether you're dealing with OCP or MMP, but unfortunately, it has a very high negative yield with respect to the direct immunofluorescent test that we subject these eyes to. I would like to understand from you whether your biopsy results are as highly negative as what we normally see in our patients. And most of the times, the diagnosis is clinical, and your initiation of management is largely based on your clinical diagnosis rather than basing it on the biopsy. Because waiting for the biopsy to be positive and then initiate management in a condition which we know is vision threatening and can lead to corneal blindness, in my opinion, is something which should not be adopted. And therefore, most of us who see this condition with a biopsy negative result on immunofluorescence will still continue to treat these patients with immunosuppression. The management of SJS versus OCP differs significantly in the fact that we rarely use immunosuppression in Stevens-Johnson syndrome, whereas immunosuppression forms the mainstay of treatment as far as OCP is concerned. So this was the paper that we published more than a decade back on the comprehensive approach to ocular consequences of Stevens-Johnson syndrome, where we categorized the intervention into what you could do in the acute versus the chronic stage. And in the chronic stage, which is when patients get referred to us as ocular surface specialists, we divided the interventions into procedures that stabilize the ocular surface, tectonic procedures, and visual rehabilitative procedures, which helps us to prevent further deterioration of the ocular surface in these eyes. And we shall look at a few of the prominent interventions that we need to do in these patients. So as far as the surface stabilization procedures in Stevens-Johnson syndrome is concerned, it basically addresses the mechanical inflammation in these eyes, and there really is no role for topical steroids to control the inflammation when the cause is mechanical. Immunosuppressives have a very, very minimal role in Stevens-Johnson syndrome, especially in a unique subset of patients which we had published regarding those who carry a very unique cytokine signature in the chronic stage of SJS that we have labeled as non-responders, who generally tend to not respond to any of the conventional management approaches that we have highlighted in these patients. So when you look at the various options for SJS versus OCP, well, immunosuppression comes first, and immunosuppression is probably very rarely used in SJS. So what exactly are the causes for inflammation in Stevens-Johnson syndrome? Yes, it is disease related. The initial insult itself leads to primary limbal stem cell deficiency in these eyes, and related to the sequelae of the disease is the inflammation that occurs secondary to the dry eye, the adnexal conditions, the lid margin keratinization, and the secondary limbal stem cell deficiency, wherein the first half is primarily immune mediated, which happens during the acute attack of Stevens-Johnson syndrome. And most of the sequelae that we see in the chronic stages are purely mechanical. The reason why I am emphasizing on the mechanical aspect or the causes for continued inflammation in patients with Stevens-Johnson syndrome is because I would like to iterate here that for mechanical causes of inflammation, topical steroids have really no role to play, because you are not addressing the root cause for the inflammation in these patients. When we talk about surface stabilization, I think one of the most simplest options or procedures that you can offer to these patients with Stevens-Johnson syndrome is punctal cautery. The understanding that puncta are stenosed in most of these patients, and they are not even subjected to syringing to confirm the patency of the nasolacrimal duct, is something that pushes us back in the management of these patients, because you will be surprised that more than 70% of these patients have a patent nasolacrimal duct, and all that is required to be done is a punctal cautery, a simple OPD procedure where you just need to occlude or cauterize the punctum with a handheld battery cautery, which is what we are doing here. And it's extremely essential that you keep the cautery switched on till you pull it out, so that it completely chars the punctum and the proximal half of the canaliculus, and that helps the punctum to completely scar after the procedure is done. So another point that needs to be remembered when you do a punctal cautery is avoid topical steroids after the procedure is done, because steroids are anti-fibrotic, and what you want here is fibrosis of the punctum, and therefore steroids again are not prescribed post-operatively after a cautery is done. And this is just to show you how a patient who couldn't even open her eye prior to the punctal cautery is today talking
बट धीरे धीरे
about
करके मैम के पास आके, सर के पास आके आपको एक होप मिलेगी, मेंटली आप थोड़ा सा सपोर्ट मिलेगा कि हाँ अब तो सही हो ही जाएगा, आपको एक प्रॉब्लम नहीं मैम
So
सर
you can see how she's able to actually open her eye and carry a conversation compared to prior to the procedure, where she would just be keeping her head down, not really opening it. But it's not just one procedure that makes or brings about the change, it's multiple interventions. So she required also a mucous membrane grafting for her lid margin keratinization, which brings us to the second most important aspect of surface stabilization in patients with Stevens-Johnson syndrome, where the lid margin keratinization, which causes significant mechanical trauma on the ocular surface, needs to be addressed, especially when it causes corresponding corneal changes in the form of corneal staining and corneal vascularization, which are basically the indications for mucous membrane grafting. And this is a surgical video of how the grafting is performed. We remove the keratinized lid margin, and then subsequently the lip mucosa is harvested, and it's always the lip, not from the cheek, because the cheek mucosa is usually very thick and fat, and that's something that you don't want. You remove just clean off all the submucosal tissue and ensure that the graft is absolutely thin, because what you're replacing is just the conjunctiva, and the suturing is done only to the edge of the mucosal graft and the edge of the skin, and the rest of the graft is secured to the bed using fibrin glue. So you can see that it is absolutely flush with the surface and does not protrude out from the eye, or is even not even visible when you look at the eye from the outside. Postoperative management again in patients with mucous membrane grafting is just topical antibiotic and lubricants, and again steroids, either topical or systemic, do not form part of the routine postoperative regimen. In the last 2 decades, I have actually lost count of the number of mucous membrane grafts that we have performed. It probably runs into actually thousands. The one that we had published around in 2015 was almost close to 800 eyes. And this is how the post-operative appearance of the graft is, where you can really not make out that there is a graft that is actually present in the eye. And this is again a few more pictures of how the appearance of the graft looks following the procedure. And what is essential here is to remember how not to do a mucous membrane grafting, because sometimes you end up having these bulky grafts which cause more harm to the ocular surface than good, because you end up disturbing the tear film significantly. You end up causing an ectropion, and you end up causing significant damage to the ocular surface, which is what you sought out to protect in the first place when you decided to do a mucous membrane graft. So the absolute flushness of the mucous membrane graft and the correctness of how it needs to be done is emphasized here. And this is a recent patient that I operated upon 3 months back, where you can see the preoperative. This was a procedure that was done elsewhere, and she approached us asking if we could revise the graft for her, which is extremely challenging and extremely difficult, because to go in and operate on this eye, to provide her with more of a cosmetic improvement, which is not our primary indication in patients with Stevens-Johnson syndrome. But yes, this is how she looks now after the correction has been done. But this is to highlight how one should perform an extremely good mucous membrane graft in the first sitting itself, because revising these procedures is not an easy task. Along with these procedures, the scleral contact lens is again a very, very important tool that we use in the management of these patients. And this is a child who is
Open your eyes.
without
Smile.
the contact lens, and this is with the scleral contact lens. You can actually see how comfortably she opens the eye, and this is the kind of change that you can provide to the quality of life of these patients when you provide them with a scleral contact lens. This was a hallmark paper under the lead authorship of Professor James Chodosh that we were all a part of in penning down the guidelines for management of SJS, the chronic, the ophthalmic involvement in both the acute as well as the chronic stage, which is something that I recommend that everybody goes through when you're treating patients of Stevens-Johnson syndrome. Mucous membrane grafting for lid margin keratinization. I think we cannot underscore the importance of this intervention in patients. Somebody was asking me yesterday whether the vascularization will actually reverse, and this is the same patient pre and post the mucous membrane graft, where if the changes in the cornea and the limbus are still in the reversible stage, you can actually see a significant improvement in the corneal clarity, the corneal vascularization, and therefore the vision in these patients. But however, if the changes are irreversible, there might not be any significant benefit that the patient might derive, but at least you would be in a position to prevent further deterioration of the ocular surface. So there has been a paradigm shift in the management of patients with Stevens-Johnson syndrome over the last couple of decades, and today we classically talk about the windows of opportunity in Stevens-Johnson syndrome that we as ophthalmologists have mandatory roles to play in. I think I will shift focus from Stevens-Johnson syndrome to ocular cicatricial pemphigoid with respect to the management, where we've already discussed about the role of biopsy, diagnosis, most importantly pictures, photographic documentation that helps us to document the progression, because that is the hallmark of the disease in OCP, to differentiate it from other cicatricial conditions, and the various other means that help us rehabilitate these patients visually. So topical steroids really have no major role to play in patients with OCP, and it usually is systemic steroids and systemic immunosuppression along with a rheumatologist, and building a good rapport with these patients, because compliance is the only thing that helps us ensure that the condition remains under control. It's a step-ladder approach that we adopt. I understand here there are differences in the immunomodulation that is used, but we have very good outcomes with mycophenolate, with rituximab. These are the two main drugs of choice for us, and of course cyclophosphamide when it does not respond to either of these. So this was a patient who basically was biopsy negative, but we did treat her to as ocular cicatricial pemphigoid, and this is just to show how and what happens when you discontinue the immunosuppression, where she came back after a few years discontinuing the medication and came back with an infection, a bad surface, and worsening of the eye. Subsequently, yes, we had no other option but to do a Boston type 2 keratoprosthesis for her. She got back her vision of 6/6, which continues to be maintained, but there's nothing to beat an eye that could have been well controlled without discontinuation of the immunosuppression, which is to highlight the importance of continuing the immunomodulation in these patients for almost an indefinite period of time. As far as pertinent queries with respect to immunosuppression is concerned, there are so many dilemmas that arise in the minds of youngsters who are starting off with treating patients with OCP. When do you start? What should be the dose? How long do you continue? And when do you decide to add or change medications? So this was a patient where it also highlights the serial pictures that are taken, which shows you whether the condition is actually progressing or not, despite being biopsy negative. Till date, till last month, she comes back and sees me once every 4 months to make sure that the disease is under control. So this girl, we decided to actually reduce her medication, but there was a slight increase in her cicatrization, after which we went back to the increased dose of the immunomodulation, and she continues to be stable since then. So the idea here to highlight that the immunomodulation needs to be continued indefinitely. As far as this other patient was concerned, I think this is the earlier picture that I already showed. This was a patient who had other skin lesions. You can see the skin lesions. The skin biopsy was also positive. So was the pharyngeal biopsy where he had lesions. So this was not just ocular MMP, but it was systemic MMP. This was a patient who was treated with mycophenolate, with rituximab, and you can see how the condition has progressed, but now continues to remain stable, and indicates how a step ladder therapy in these patients, because he then developed urethral lesions. So this was a pan-mucosal mucous membrane pemphigoid that the patient presented to us with, which we treated in coordination with the rheumatologist. So as far as answering those questions are, well, we do start immunosuppression when we see inflammation, when we see progression, and when, of course, it is vision threatening. It depends on the drug as to what the dose would be, and you will need to continue these patients indefinitely on immunomodulation. And there is really no role for topical steroids except supportive. As far as the role of biopsy is concerned, we need to do a biopsy in these patients. Why do it at all in the first place if it's going to turn out to be negative is a question that a lot of students do ask at times. But the idea is you could sometimes be dealing with a similar manifestation that could be linear IgA disease, wherein the treatment of choice is dapsone and not mycophenolate or the other options that we use for mucous membrane pemphigoid. This was a patient who turned out to be lichen planus, and therefore, since you can have other conditions that can mimic ocular cicatricial pemphigoid, biopsy does have a definite role. This is a patient of pemphigus vulgaris, and therefore biopsy is mandatory for us to know if we are dealing with some other condition that is mimicking OCP. This is the algorithmic approach that we normally adopt in patients with OCP. First, categorize them into whether it is vision threatening or not, whether it is inflamed or not, whether it is progressive or not, and which helps us decide when and how to initiate and then escalate the treatment of OCP. Visual rehabilitation in end-stage ocular surface disorders, whether you're dealing with Stevens-Johnson syndrome or whether you're dealing with OCP, is keratoprosthesis, either the OOKP or the Boston type 2. Boston type 1 is usually not recommended for eyes with Stevens-Johnson syndrome. This is a patient who continues to maintain 6/6 vision 19 years after the procedure has been done, I think 20 now, in 2005. This is a patient of OCP, 83-year-old, maintaining a vision of 6/9 with the type 2 keratoprosthesis. And I always also believe in something that I call as the 4 Ps in the K-Pro plan chart, which is preventive, preemptive, proactive, and palliative. So the preventive aspects, you want to try and prevent the patient from reaching to a stage where they would require a keratoprosthesis, and that, I believe, in Stevens-Johnson syndrome has been with the help of the various surface stabilization procedures that I already discussed about. Preemptive, do you have any other option that you can try before you actually take up the patient for keratoprosthesis? Yes, we have done a few patients of alloslet in patients with Stevens-Johnson syndrome under immunosuppressive cover. So this was a patient who underwent alloslet under systemic tacrolimus and mycophenolate cover, who continues to do well. This is another patient of Stevens-Johnson syndrome, severely inflamed, with alloslet under systemic tacrolimus and MMF cover, and you can see that we have been able to rehabilitate this patient visually. A very young child of SJS, where we didn't have any other option because we don't normally advocate keratoprosthesis in young children, where the surface has been holding up for almost close to 6 years now with the alloslet under immunosuppressive cover. Similar procedures done for ocular cicatricial pemphigoid, where we have been able to rehabilitate these patients. But alloslet is something that one needs to take up with a lot of caution, because you are touching the cornea in these eyes, and if the epithelium does not heal, you can end up with a perforation, and therefore selection of cases for alloslet in these conditions is extremely crucial, because this is a patient where it actually perforated, and then finally we had to take him up for a Boston type 2 keratoprosthesis, which means that you always have your plan B ready when you are touching the cornea in these patients. This is the patient who's been maintaining a vision of 6.6, 2005 to 2025 now, maintaining a 6.6 vision with OKP in one eye and the other eye as a spare eye for subsequent intervention if something happens to the existing eye. So this is, I think, a very important slide where I like to divide dry eyes into dry eye without cicatrization and dry eye and cicatrization without dry eye, because if you have cicatrization, then there are very few conditions that you're dealing with, and Sjogren's does not really present to you with cicatrization, and you need to be very clear as to what is the disease condition that you're dealing with, because that is what helps us to manage these patients effectively. Coming back to this particular patient whom I started off with, who was diagnosed as OCP, when we went back to her history, the entire family had been affected with adenoviral conjunctivitis 2 years back, and you can have cicatrization and dryness in patients who have had a very severe adenoviral conjunctivitis, and her dry eye was secondary to that. So her diagnosis was post-conjunctivitis cicatrization related dry eye and not OCP. So this was a patient who had a misdiagnosis where all that we did was a punctal cautery, and you can actually see that she continues to maintain a very stable surface with no change in her cicatrization over the years. So this was a classic case of a misdiagnosis, whereas the other lady who presented to us, who had been treated as rheumatoid arthritis, considering the fact that she had cicatricial changes, we were very sure that we were dealing with either a rheumatoid arthritis with OCP or just OCP, which had been missed. So she was then subsequently treated with cyclophosphamide with mycophenolate, and the eye continues, beautifully resolved, quietened, and continues to maintain its quietness over a period of the last couple of years. So on one side you have a misdiagnosis, and on the other side you have a missed diagnosis, which is extremely crucial to ensure that you don't give unnecessary intervention for these patients and you don't delay intervention in a vision threatening condition such as this. This is just to show how a conjunctival argon laser photocoagulation or a fine needle diathermy actually helped us significantly improve the surface in a young patient with Stevens-Johnson syndrome. And this is to show a couple of cases. So this was, I just wanted to ask, I mentioned about mucous membrane pemphigoid. So what would be the diagnosis in a patient who presents to us like this with significant cicatrization? So there was somebody who had thought that she had a vegetoid spread of sebaceous gland carcinoma. She had been subjected to a 8-map biopsy, which turned out to be negative. And then when she came to us, this was the picture with a diffuse epithelial defect on the cornea. And the fellow did all the regular history taking, any oral lesions, no, nothing, everything fine. But what I always do when I see these patients is ask them to open their mouth and self-evaluate the mouth. And you can see that huge lesion in the mouth. They will have no complaints of oral lesions, but you will find something like this in the eye. So we subsequently started her on systemic steroids, and she's starting to heal. And you can see that within a week of starting the systemic steroids, the oral lesions have significantly improved. Another post-conjunctivitis cicatrization and dry eye that was treated with oral immunosuppression, where all that it required was a punctal cautery, and you can see the significant improvement in the inflammation as well as in the dryness, which tells us how diagnosis in these patients helps us manage these patients effectively. This is another patient of post-conjunctivitis dry eye, where sometimes the eye looks absolutely quiet, but that's the kind of staining, and that's how a yellow filter, a yellow barrier filter really helps us to get these manifestations very prominently. So in conclusion, I think There are several aspects beyond what meets the eye in cicatricial disorders, and careful history taking is extremely important in these patients, and one need not feel very pressurized to have a diagnosis in the first visit, and what is important is to build a rapport with the patient. I have not forgotten about the young girl whom I started off with. So this is the same 3-year-old child whom we started on tacrolimus, systemic steroids and mycophenolate. We knew we had nothing else to do because you couldn't have done a keratoprosthesis in a young child like this. I went ahead and did an alloslet with mucous membrane grafting to the lids, and that was the immediate post-operative picture. This is subsequently, that's the reconstruction of the eye in both her eyes. That's how she looks now. And this is the same child.
So beautiful, madam.
Surely in that you like a wow.
This was a very popular meme where she's trying to say that's so beautiful, looking like a wow. That's what she's trying to say. And I think I'll just finish by saying that every scar tells a story, and as clinicians, our responsibility is to ensure that it is a story of resilience and recovery. Thank you so much.
Thank you very much, Dr. Geetha, for this valuable information and those different cases. We'll open the floor for discussion or questions. Dr. Samar.
Thank you. Thank you, Dr. Geetha. I really enjoyed the presentation, and I like the way how you divided it into a miss and misdiagnosis. That was something really innovative and attracted our attention. One thing I wanted to ask you is about the neuropathic pain. How do you deal with the neuropathic pain in these patients?
So I
Symptomatically, yeah, relief.
Yeah, so neuropathic pain, or what we refer to as pain without stain, that falls significantly under the category of non-cicatricial dry eye diseases. And I think that is something that will deserve an entire class that's dedicated to that. In cicatricial disorders, what we have seen is that a lot of the pain is because of the actual manifestations that I showed. And to a large extent, taking care of all this significantly brings down the discomfort. But to slightly touch upon and answer your question, we have to rely on medications such as gabapentin, or one of those which act on the central nervous system to reduce the pain threshold in these patients. But this is not specifically in relation to cicatricial conjunctival disorders, but more so in patients with the dry eye disease where they have a lot of pain. So we normally try and instill a drop of anesthetic to see whether they feel better or not. Then we subject them to a scleral contact lens to see whether they get better or not. Because if they still continue to experience pain, even with a scleral contact lens, where you have to a large extent eliminated the external factors that produce pain in the eye, then you kind of narrow down your diagnosis to, yes, we're probably dealing with a neuropathic pain. And that's when we get in the neurologist into the picture, and we try and see if we can give them low dose medications that can reduce their pain threshold.
So I'm curious to know that, do you really put them on these oral medications?
Yes, we do. In fact,
you came across
not
a lot
of patients. That's what I said. This is more specific to non-cicatricial dry eye diseases where we have pain without stain. It's extremely rare to have patients of cicatricial disorders who don't have stain. So most of the pain in SJS and OCP is related to the findings, to the organic findings that you can see on the surface, vis-a-vis the patients of dry eye disease who complain of a lot of pain, but you can't really see anything that is happening in the surface that explains why they have the pain. But in these patients, if you're asking about an added component of neuropathic pain after you have addressed all the other factors, I think we don't really put them on any additional medication because they are already on a lot of medications. But at times, if they are extremely symptomatic, yes, maybe for a couple of cases we've got the neurologist into the picture, but it's extremely rare otherwise.
Interesting, because I've seen it in younger patients with Stephen Johnson in particular. Even after we subject them to mucous membrane graft and keeping them also on scleral contact lens, they still have that manifestation. So thank you for adding that information. The other thing, I came across one of the patients a few years ago, whereby a patient presented with a lot of, stem cell-like, related presentations, all the signs and symptoms and everything, and by somehow the patient was in the age of 50, 55, something like that, and in some places they've done auto transplantation of the stem cell from the other eye into this eye, and aggressively also dissected all the conjunctival growth and so on. And then when the patient referred to us, I saw an area that were highly suspicious of corneal OSSM. And unfortunately, that's the point, is that the biopsy is a very essential, or even subjecting whatever you excise from the eye to the pathology is essential, even if you're going to do the stem cell transplantation. So then I took the patients and I took all what they transplanted, and I did the map, and then I found that it was OSSM. So that was also one of the big stories that I always tell the residents and fellows, that really we need to be careful not to directly go to the last resort, just a surgery, before carefully address all the presentation of the patient and go step by step, like what you mentioned.
Absolutely. I think vigilance and a very rational and logical approach to these cases is extremely essential, so that we neither over or undertreat. Yes, Sarah.
Dr. Sarah?
Atopy-related cicatrization.
Sorry?
What is your approach to patients with atopy-related cicatrization?
So yes, we do see patients with atopy who do have, but they usually don't have very severe cicatrization as what you would see in a classical case of MMP or Stevens-Johnson syndrome. So atopy, we also treat these patients in coordination with the dermatologist, and based on the severity, these patients are started on systemic medications, especially systemic tacrolimus now over systemic cyclosporine, and we are also treating these patients with the allergy specialists if their IgE levels are high, whether they need any monoclonal antibodies related to the IgE that keeps the atopy under control. So it's an integrated care that is provided to patients with atopy, where topically we use the topical tacrolimus, the topical anti-allergic medications, keep them on very low dose steroids because you don't want them getting complications related to steroids, but it is a coordinated care with the dermatologist.
Thank you, great lecture. We manage quite a lot of glaucoma drop-induced cicatricial disease, co-jointly with Dr. Ahad. And patients are usually on multiple drops, and so it's difficult to know sometimes which drop is causing the problem. Sometimes I stop all the drops on all Diamox and reintroduce them one by one. So the first question is, which is the least likely class of drop to cause this problem? And second question is there any immunological or histopathological features which are more suggestive of glaucoma drop-induced cicatricial disease than OCP?
I wish I had a very straightforward answer to that question. That's a challenge that I think we all face. And so the understanding as of now is that glaucoma medication related cicatrization is either related to the molecule itself or to the preservative. So initially we used to believe that it was the preservative, and therefore we moved on to preservative-free anti-glaucoma medications. When we did that, we still saw that we were seeing cicatrization even with preservative-free medications, and therefore we concluded that the molecule itself leads to cicatrization. Thirdly, whether it is a drug-induced pseudo-cicatrization, where things will halt if you withdraw the drug, or whether it is a true ocular cicatricial pemphigoid in a patient who is on anti-glaucoma medication, which has been triggered by the AGM or has got no relation to the anti-glaucoma medication whatsoever are questions that we don't have answers for. So what I normally do is I stop all the anti-glaucoma medications, start them on oral acetazolamide, wait for the eye to quieten down completely. But that is one class of patients where I do always subject them to a biopsy, because there was one patient who did turn out to be positive on the direct immunofluorescence, because then your dilemma is to start them on immunosuppression, and then you are discussing with your glaucoma specialist about further management of the glaucoma, because again trabeculectomy and the possibility of scarring with a trab, the glaucoma drainage device with again other issues. But yes, we have successfully handled a lot of these patients. If you ask for the least or the most common drug that leads to is probably still timolol, whether it is preservative free or not. And so we do start these, and your prostaglandin analogs, you don't want to use them because you don't want to incite inflammation related to the medication itself. So you're left behind with very few choices. Saflotan used to be available for us in India, but it no longer is, the preservative free. These are, you just have to introduce it, and but you have to keep a very close watch. Patient needs to understand that they need to come back for a follow-up regularly. And sometimes you need to keep them on systemic immunosuppression alongside. So, pathologically, at least the ones that we subjected to histopathology and to DIF, no, there was no change. There was no difference. No.
Any difference in the cicatrization if the patient was on anti-glaucoma drugs versus slow-release implants? We don't have an access to those.
Sorry, I didn't get your question.
Any differences? Would the implants reduce the rate of cicatrization in glaucoma patients?
So we do have the drainage device doesn't the fact that the MIGS, you're talking about that? For the elution of the medication. I think if it is still going to be released onto the surface, you will have to withdraw anything that releases the medication onto the surface if the medication is the inciting factor. Doesn't play a role.
Thank you very much, Dr. Geetha, for your very informative lecture, which we all get benefit from that. My, these two, Stevens-Johnson and OCP, this is a continuous process, starting from zero till the full picture. And, during this time, there is cooking things and pathological changes. And I think intervention and to stop these things is the most important. For example, Stevens-Johnson started the first 2 weeks to 4 weeks, and most of the time, ophthalmologist will not see.
Yeah.
It is pediatrician and children and adult medicine. And they came when they started having these complication and ophthalmology symptoms. Also, the OCP, this is a long process, chronic, and always coming from one doctor to other doctor and these things, and there will be misdiagnosis, there will be many things during this process. What is your recommendation for Stevens-Johnson to start as for resident, for ophthalmologist, for anywhere, and also for the OCP? The other things which I'm always thinking about, to have a acetone or something to implant, and especially for the OCP, to have continuous release and to prevent this process and to maintain the eye as much as we can, because most of the time we are dealing with the complication and all these things and surgery. I think our role to prevent it from beginning, if we can. And one of the things that I'm thinking about is to have something to have subconjunctival sustained release for this thing. And thank you very much again.
Thank you. I think you have raised very pertinent questions with respect to the management of these conditions, especially for those who are starting off. It starts from examining these patients in the right way and identifying and documenting every finding that you see in these patients. If we have access to these patients within the first 2 weeks, then amniotic membrane grafting has a role to play. It is not a panacea. It is not something that prevents the chronic sequelae of SJS, but it is something that helps to reduce the severity of the scarring that you see in these eyes. And therefore, it should be. That is why it falls under a mandatory role of the ophthalmologist if you are seeing the patient within the first 2 weeks. If you're seeing the patient after that, then you have to evaluate the patient and figure out what is the cause for the inflammation, and whether you do anything or not, at least try to avoid the use of topical steroids as a quick fix for the inflammation that you see in these patients, because this can cause a lot of irreversible damage in the form of glaucoma if it occurs in these patients. And if it is possible, then you have a very logical way of approaching the management by doing a cautery or a mucous membrane grafting and ensure that you stabilize the surface. For OCP, you need to have a very, very high index of suspicion and ensure that you get biopsy done. And if at any point in time you feel that it has gone beyond the limits or beyond the scope of you managing the patient, then it is better to refer them to a tertiary eye care or a specialist who can handle these patients appropriately. Sustained release of you mean in the eye? Low.
Very low. And that's why I'm thinking about having something to have a continuous, for example, 1 month, 4 months, whatever.
Quieten the surface of the eye. For OCP, I don't know whether a sustained release steroid will help, because then you're targeting only the local, whereas the process begins elsewhere. It's a systemic condition where the antibodies are targeted against the antigens in the eye. Unless we have something that helps us prevent that antigen-antibody complex from getting deposited in the eye, treating in the local environment is probably not going to be the solution as far as OCP is concerned. But for Stevens-Johnson syndrome, again, we don't want to expose these eyes to steroids and other immunosuppression when that is not the relevant option. So we first take care of all the mechanical causes and then we move on to immunosuppressives.
Regarding to the importance of the biopsy to rule out other diseases, do you recommend it also for typical OCP cases? If the patient presents with typical history, typical ocular finding, should I start the medications immediately or I go for biopsies?
I think the consensus at this point in time amongst ocular surface specialists across the majority of us is yes, so a so-called typical OCP could end up being a linear IGA or a lichen planus. So what are we defining as typical OCP? So it's especially to filter out these typical cicatricial diseases that we are subjecting the eye to a biopsy. So rather than assuming, yes, there's always this question of evidence versus eminence. We sometimes feel we have seen 100 OCPs and therefore I know how OCP looks. That's what we call as eminence. And evidence is where you do a biopsy and convince yourself and the patient as to whether you are dealing with it or not. But yes, sometimes evidence cannot always provide you with the information that you're looking for, which is when eminence should step in and tell you whether this is typical or not. So to answer that question of yours, I think yes, biopsy should be done in all cases. For you to have a documentation that you did attempt to do a tissue biopsy, you did try and see if you could get a confirmed diagnosis of the disease, because whatever said and done, you're starting these patients on medications that do have a lot of other implications.
Thank you, Dr. Geetha, for a great presentation. I have just one question regarding keratinization secondary to ocular rosacea, if you have any experience in managing those patients.
Again, in ocular rosacea, you will not see keratinization that's like this. You will not see a lid margin keratinization that's rubbing on the ocular surface. It's more limited to around your meibomian glands, which does not usually have a significant impact on the ocular surface. So there we treat the ocular rosacea. Maybe you can subject those eyes to the IPL or the tea tree oil if you are suspecting Demodex as one of the causes for the rosacea itself. So there the management is a little different from, you don't really have to resort to surgical intervention for the keratinization over there. And somebody asked about the role of vitamin A yesterday, so maybe there you could have a role of vitamin A.
We'll have our last question, Dr. Mohammed.
Okay, regarding the biopsy, so we know that we have a high negative yield result, and what's your technique for getting the most positive? And would you repeat it if you have highly suspicious and you already get the negative, or you do 2 eyes to get more positive result?
Yeah, so I did have a video of how the biopsy should be done. To maximize the yield, so between the 2 eyes, you normally want to take the biopsy from the eye that is actually showing evidence of inflammation if one is showing more inflammation compared to the other. If there is active ulceration, then you obviously avoid the area of ulceration because you don't have the epithelium there at all, and it will be a tissue that's not going to give you any information. So the biopsy is always taken adjacent to the area of maximum inflammation or ulceration, so that you get the epithelium and the basement membrane in the biopsy tissue for them to assess the immunofluorescence. You can use a trephine, but we just use it to mark the amount of tissue. So usually you don't want to rotate it, because that rotating action or cleaning with the swab when you are trying to take the biopsy itself can shear the epithelium from the basement membrane. Ultimately, the idea is for them to see the complex intact so that they are able to identify the immunofluorescence in the basement membrane zone. And what we do is we now take a more linear kind of a tissue and then divide it into 2 parts, one always for histopathology and one for immunofluorescence, so that in histopathology you rule out the other causes such as your mascarades or your sarcoid or atopy, and in your DIF you get the confirmation of the OCP. I always combine it with small biopsy from the oral mucosa, because that sometimes increases the yield. The beauty or otherwise of the disease is that the oral lesions always heal without scarring in OCP. So when you examine the oral mucosa and you don't see any scar, it doesn't mean that you're not dealing with mucous membrane pemphigoid, and therefore sometimes we, especially when you see a lesion like this in the mouth, you can actually give a biopsy from the oral mucosa along with the conjunctival biopsy. So instead of taking it from 2 eyes, I normally take it from the eye and the oral mucosa, which is 2 different mucosal specimens, which might sometimes improve your yield.
Thank you very much, Dr. Geetha, for this valuable
Thank you.
information. And